Good afternoon, good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent and the response that Africa CDC has across the member states. Today, we are joined by His Excellency Dr. Jean Kaseya, the Director General of Africa CDC, and I will now hand it over to the DG to start the session. Over to you, Dr. Kaseya.
Good morning, good afternoon, good evening for some of you. I'm so glad to join you today, but let me thank my colleague, Dr. Yap, who was with you last week. And you can see in Africa CDC, we have so many people who can, if the DG is not there, to share what we are doing. I just landed. I was in Dubai and Abu Dhabi. I just arrived 1 hour ago. From the airport, I say we need to talk because immediately after this press conference, I have to fly to Nairobi. We need to meet the government of Kenya to discuss a number of issues. But let us start with the presentation. And next slide, please. I wanted to update you on what we did from Thursday last week to date. And you'll see it's based on some themes. I was in Mozambique on Thursday to meet the president to discuss how to reinforce the human resources for health and how also we can have more domestic resources. I got commitment from the president to start to increase health budget in Mozambique and to become a person more vocal for that. Even he requested his minister to be part of the committee that we are putting in place to implement the three-pillar strategy that now all of us we know. I had also opportunity to meet colleagues coming from the ward where we have the National Public Health Institute and to address the message from Africa CDC on the way we need to strengthen the National Public Health Institute. Next slide. Then the same Thursday I left Mozambique, I landed to Addis Ababa to meet on Friday the new chairperson of African Union Commission and to brief him on his role to support the agenda of Africa CDC and also to meet the CEO of Ethiopian Airlines. If with the president we discussed more domestic resources, with the CEO we discussed more innovative resources. Today, Africa is ready to put in place some taxes for more pandemic preparedness and response, and also for more solidarity, because we know that not all countries have resources to support this agenda. Next slide. Then I was in Abu Dhabi. The agenda in Abu Dhabi is more blended finance. It means more investment to the African system for local manufacturing, for the digital agenda, for the supply chain management, for health workforce, but it's mostly investment. And it's also to learn from what this country is doing. It means more innovation in the health sector. Today, Emirates is one of the countries making huge progress in the health system by using AI. I can say we are moving toward a strong program with this country for Africa, and that will announce maybe in a few weeks or months. Next slide. Then I was in South Africa. We needed more domestic resources. I gave you the example of Mozambique. We needed more innovative financing. I gave you the example of Ethiopian Airlines. We needed more blended finance. I gave you the example of Abu Dhabi. In South Africa, it was more medical countermeasures. We need to manufacture our vaccines, our medicines. I was sharing with them what some of us we know. I think this one, we need to keep it somewhere. More outbreaks, less resources, but we are still struggling with our medical countermeasures. This is why we took time to inform the G20. If we don't reverse that, we are accelerating the occurrence of an African-made pandemic. Next slide, please. When we talk about Mpox, we start to have some good news. The good news is we see a decrease in terms of notified cases across the continent. And we can still see some increase in terms of confirmed cases because we are testing more than last week. But that one doesn't mean that Mpox is not decreasing. Overall, we see this decrease across the all countries affected. And I had to make a decision. I'm calling for the emergency consultative group meeting on the 17th of May. Our expert, it means 4 weeks from today, they will analyze all data. They will analyze all evidence we'll provide to them, and they will tell us if we still need to continue with public health emergency of continental security and what we need to do more. Next slide. When we talk about this effort at continental level, you can see that DRC, this huge increase in terms of notified cases, we move from 2,099 to less than 1,500. Since we started with this response, it's the first time that we have less than 2,000 cases in a week. This is good news. And we can even see, despite the challenge in terms of testing, but we can see there is also a decrease in terms of confirmed cases. I wanted to show you this letter that I got from the Minister of Finance himself. He sent me because I was doing the follow-up. It was known that DRC wanted vaccines, wanted us to pay some custom fees for vaccine. That was not correct. But I said to the Minister of Finance to officially write and give opportunity to say there is a waiver for all vaccines that we're importing to support Mpox response. And this is the letter. It means I am counting on you, colleagues, journalists, to clearly say that this issue doesn't exist anymore in DRC. That will help us to vaccinate more people, more than the 525,000 that we already vaccinated. Next slide. All effort that we are doing is paying. You can see the decrease among healthcare workers. From November to January, we have almost 50% of the decrease, because we are reinforcing what we call IPC, infection prevention and control. And if we don't protect our health workers, we are not protecting the community, because they are also a source of transmission of the disease, while we are missing a number of people who can take care of people who are affected. Next slide. Not only IPC, but you will also see in terms of contact tracing, our team, the IMST team based in DRC and the local office in DRC, they are supporting the country to do more contact tracing. And this is why we can attest today, if you have more contact tracing, but less cases reported, it means there is a decrease of the mpox in DRC. Next slide. You will see in Uganda, there is some increase, but we are talking about overall number. You see, Uganda, the average is around 200, 250 cases. In DRC, the average was around 3,000 cases. This is why, even if we have this increase in Uganda, but we can see that if you compare with the previous 3-4 weeks, there is a decrease in terms of number of cases. We know people are dying mostly because they have some comorbidities. And in Uganda, we saw that more than 55% of people who are dying were HIV positive. This is why we decided to change our approach. Some of these people, they were newly tested HIV positive. We need to intensify not only the mpox, but the approach we have today with IMST is to consider all comorbidities, including undernutrition, plus other outbreaks that we have, measles, cholera, and others. I think this integrated approach is making our response more efficient, and countries, they can see we are using mpox as the entry point to tackle all other outbreaks. Next slide. It's just for us to understand that mpox is mostly in Kampala than other regions. And this is why it's important, knowing that we had recently, and we didn't declare the end of this Marburg outbreak, Ebola outbreak. I think we had it in Kampala, and we are still responding by putting our effort together to support a comprehensive response for all outbreaks in Kampala, that is the capital of Uganda. Next slide. Yes, we don't say it's the end of mpox. We see some countries out of Africa reporting. This is why we are saying in 2023, we had the mutation and the clade 1B. In 2025, we have the ApoBec 3, 1A. We don't want to see another mutation because no one knows what will happen. There are countries like Switzerland, like South Africa now, they have 7 cases of 1B. But in Switzerland, it was someone who flew from Africa to Switzerland, and he was tested, but in the UK, it's someone without any history of traveling. We are working together with our colleagues from UK, from China, from Abu Dhabi, and from Switzerland to see how we can strengthen our response. Next slide. When we say to strengthen the response, as you know, our plan was a 6-month plan that ended in February. Then we developed the plan 2.0. This 2.0 is covering from April to August. We want to accelerate in a number of areas. We want to have more cross-border collaboration using the tools that we have today. We need to accelerate with vaccination because now the vaccine is available. As you know, we decentralized the diagnostics. Even in DRC, we see an increase despite what's happening in the eastern part of DRC. And we give power now to community health workers by supporting them to notify all cases. This is what we call to intensify the mpox response and to bring mpox as legacy on how we can sustain the response when we have other outbreaks. Next slide. Vaccines. Kenya got vaccine. I will be there. I will talk with the minister. We are starting the campaign. A number of countries are vaccinating, almost zero resistance. And we are saying Africa wants vaccine. Now, with the waiver that we got from the Minister of Finance, DRC will also accelerate with the vaccination. Next slide. We wanted to update you on the Ebola outbreak. As you know, since 15th of March, we didn't have any new case. We are crossing our finger. We still have 11 days before declaring end of this outbreak. We hope next week and the week after, we can say the country is out of this outbreak. But everything is moving. We are supporting all aspects of the response together, combining with our effort with other partners to tackle Ebola, mpox, and other diseases that we have in the country. Next slide. We still have anthrax. You'll see we'll talk about anthrax in humans in Uganda. We'll talk about anthrax in animals in DRC. And we are following that with the minister and the team. We already conduct some joint investigation. And for now, 0 death. 1 case confirmed, but as we say, now in Africa, we are taking seriously any outbreak, mostly in the context of One Health. Next slide, you will talk about the same anthrax in DRC. You see in that region, I will look for appropriate word for this region, the eastern part of DRC, where we have a concentration of almost all diseases. And this one, we don't have any evidence today that humans are affected, but we continue to follow what's happening. If there is any transmission from animal to humans, we'll keep you informed. Next slide. What is killing more in DRC, in Africa? It's other diseases. We have cholera in a number of countries, Sudan, South Sudan, Ethiopia, Angola. I will be in Angola on Sunday to see how to support the response. We still have measles killing our children, and you will see it's mostly affecting the eastern part because we don't have vaccination campaign organized in this region. We are saying, we are repeating, let us create conditions for us to access people and to vaccinate, to give what they need. Otherwise, the mortality will increase and so many people will be affected. The eastern part of DRC is a major issue for us. Next slide. It's a yo-yo in terms of cases and deaths for cholera in Angola. And I said this week, we reported around 1,400 cases if we compare with 1,200 cases last week. But it's normal if we know the environment, if we know the suburban area without some wash, it means water, sanitation, and hygiene facilities. The government is doing its best to provide Africa CDC supported with vaccines like ICG, and we are continuing to provide youth support at community level and also to sensitize our people. I will evaluate the response on Sunday, and Monday I will be in Angola before flying in DC for the Springs meeting. That will give us opportunity to say if there is some changes that we need to bring to our response. Next slide. I was talking about it, about Angola. We'll evaluate. Next slide. To summarize, decrease of Mpox cases. This is why I'm calling for the ECG meeting in 4 weeks to see if we need to continue with the public health emergency of continental security. If our experts, they say, DG, you have to continue, I will continue. If our experts say, DG, we stop, we need now to restructure the response, we'll do that because we are led by science. In the meantime, we have our plan 2.0 that is guiding more to intensify the response and to build the legacy. We also discuss about other outbreaks, pushing for more integrated approach, what we call One Health. And you know, Africa CDC, we are supporting implementation of One Health in Africa. Let me stop there. I know you have a lot of questions. Some of you were following me where I was. We are at your disposal. Back to you, Margaret.
Thank you, DG. Let's take the first 2 questions from the chat group. We have Michael Garissa from Health Times in Zimbabwe. The question is, Africa CDC recently released a report on health financing in Africa, which highlights a 70% decline in official development assistance from 2021 to 2025. What immediate and long-term strategies is Africa CDC proposing to mitigate the impact of this funding shortfall on critical health programs? That's the first question. The second question comes from Kemo Cham of Mano Reporters from Sierra Leone. He says the DG mentioned that there has been decrease in cases of Mpox, but today Sierra Leone's National Public Health Agency warned that it recently seen sharp rise in cases, although it believes that this could be because of intensified surveillance measures that cases are coming up. But considering this Sierra Leone experience, couldn't it be premature to give an impression of near to the end of the pandemic when there are some countries like Sierra Leone that are yet to see the worst? Those are the first two questions. DG, over to you.
Thank you so much to our colleagues. Regarding the health financing, I think we had the opportunity to present to our colleagues for the past 7-8 weeks what Africa CDC is doing. And that document that we released, that is in our website. If you go to Africa CDC website, you'll see that. Rethinking Africa's health financing in a new era. We take the decline of ODA as an opportunity. An opportunity for our own country to start to invest more. I was meeting a minister of finance who was telling me that in some countries, the government can invest 30% in education. They find it's normal. While they're investing less than 5% in health, because they knew that money was coming from somewhere. Our strategy is clear, 3 pillars. The first one, as I was explaining, we need more domestic resources. We need countries to have clear development plans, costed and finance, national health financing plan to show us how they are providing funding to this plan. The second one is to create new money that will not come from our budget, national budget. Today, if we can put a tax for the airline ticket, that will give some millions of dollars that will support the response in Africa. We are working towards that. The third one is blended finance. We need to see more investment coming. We have some good news, but I don't like to give good news if it's not signed, it's not. But believe me, everywhere we are going, we got some good news and we'll start to operationalize that very quickly. These are the 3 pillars for our colleague from Zimbabwe. But let me also say, a study that we conducted in Africa CDC is showing even at the same level of funding today, if we have very good governance, if we stop wastage, if we stop fraud, we can make more than 40% of impact. It's huge. This is why there is a cross-cutting area. We call that good governance and efficiency on the way we need to deliver a program. Regarding Sierra Leone, please don't quote me wrongly. What I said, at continental level, we see a decrease in terms of cases because mostly Mpox, it was in DRC, in Burundi, in Uganda, as core countries. If you see a decrease in Burundi, that was the second country affected after DRC. If you see a decrease in DRC, it means overall you have a decrease in terms of cases. But it's not the DG to say it's the end of the outbreak. No, it's our scientists, our experts to come to analyze data country per country to understand with all effort we are putting in place, can we say that it can be the end or not of public health emergency for security? Even if they say it's the end, it doesn't mean it's the end of Mpox. We'll continue to respond to Mpox, but the magnitude will not be the same. I think this is what we wanted to say. And we commend the effort in Sierra Leone to intensify surveillance that is helping to have cases. Back to you.
Thank you, DG. Let's cross over to the floor. We have Janice from Bloomberg. You have the floor.
Good afternoon. Thank you again. So the question I had today was probably slightly left field in that it's not something we've discussed in a while, but I'm aware that measles is still an issue across Africa, and it's increasingly an issue around the world. And I was just wondering what your thoughts were in terms of how much of that was related to travel or anti-vaccine sentiments or cuts to international aid. And I appreciate that on the continent, with so many varying demands in terms of Mpox and Ebola and all the diseases that you've already talked about, I was wondering if you could just give me a sense of where measles falls into that, how concerned you are about that. Again, in Goma, I appreciate it might be a risk there as much as cholera or something like that because of what's going on.
Thank you, Janice. Let's take the next one before DG comes in. We have Kerry from Health Policy Watch. You have the floor.
Thank you, Margaret. My question is related to the countries that might be running out of antiretrovirals. A couple of weeks ago, the WHO said that there were several countries in Africa that were, because of the PEPFAR funding, at risk of running out of their ARVs. So I just wondered whether there's an update on that, whether you could tell us which countries there are and if there are any contingency arrangements to address that. Thank you.
Over to you, DG.
Respond to the second one, I will give opportunity to colleagues who are analyzing all data from IMST to respond to the first one, but I will give a shout out for that. Yes, Kerry, you are right. We see a number of countries. I was in South Africa 3 days ago. I was in Mozambique. I was talking with ministers of Zimbabwe, Mozambique, Zambia. Most of these countries where you even see you see a number of HIV clinics closing because of head cut. And we saw people who even are moving from a country to another one to look for ARVs. We're not thinking to see that in Africa. What we are doing, first, to refocus. We still have some money at country level, but we need to give some priorities. In Nigeria, you saw the government provided funding to cover the gap. In South Africa, it's the same. In other countries, we are mostly working with local solutions. Second, we are talking with the administration. They said this is life humanitarian intervention that can help people to remain alive. We are still waiting to see concretely how to move on. We are working with Global Fund, and Global Fund is reconsidering some of the countries to increase even access to ARVs. I think there are a number of solutions, but it's not the ideal one. As I said, we are learning from that. We don't want to see again tomorrow someone cutting funds and we don't have medicines. Regarding measles, it's mostly a combination of so many factors. Yes, movement of people, like in the eastern part of DRC. People are moving, millions of people are moving. That one is one of the reasons of this measles outbreak we can see. The second one is head cut. As I was saying, people are not vaccinated. They don't have access to basic interventions. But it's not about anti-vaccine. Africans, as I said, they don't refuse vaccine. They are welcoming vaccine. It's just this vaccine is not available for them. But I want to give opportunity to Dr. Yap and the colleagues to provide more information about the linkage, measles, cholera, and mpox.
Thank you so much, Okay, thank you. So good afternoon, colleagues. Thank you so much, DG. So regarding measles, like you mentioned rightly, there are a number of factors that actually are contributing to the spread. And in terms of the linkage around this three, I give you an example, like a country like Burundi, who is kind of doing active case search currently to actually pick out all the mpox cases in the communities. Some of the alerts that came out were investigated and turned out to be measles. And amongst these cases, we had 12 of them for the cases that came in last week. We had 12 of these were children with these 0 doses. And we had 67 of these cases that had incomplete, that they had taken just 1 dose. This is just to tell us that there's really need for an integrated approach in terms of surveillance and also in terms of testing. Looking at it also from the point of diagnostics, as IMST, what we're really pushing for is kind of an integrated approach whereby we have multiplex testing and kits that are able to detect across these different diseases that we're seeing as we detecting or conducting active surveillance for mpox. Then thirdly, we're also seeing cross-border transmission, and this has mainly been driven by conflict as well as environmental hazards, like flooding, where persons are displaced. Of course, they have to move along with their children, and these children finally end up in places where they miss vaccination and become really very vulnerable. So lastly, in TRC, we also see how we have co-infection, whereby children that are kind of hospitalized or suspected cases for mpox, which are hospitalized alongside those that are cases for measles, end up picking both. So we see there's co-infection of measles and mpox amongst some of the cases that have been diagnosed. So in all this, the summary is, as we are intensifying our response, we are taking the integrated approach, whereby from surveillance to the laboratory diagnostics to treatment, we are actually ensuring that we integrate all these different interventions. Thank you. Over.
Up to you, Madam.
Thank you very much, Dr. Mercy. We have the next question from Priyanka from Chemical and Engineering News. You have the floor.
Great. I was wondering, DG, if you had any comments on the recent global pandemic agreement draft that was finalized, and if you wanted to highlight any particular strengths or otherwise from that. Thank you.
Priyanka, you cut off. We didn't hear your initial question. Could you repeat?
Oh, I'm so sorry. I was asking if DG had any comments on the recently finalized text for the global pandemic agreement, and if there are any strengths that he'd like to highlight, or otherwise any comments he'd like.
Thank you very much. Let's take the next one before DG comes in. We have a question from Emery Makumeno of BBC. The question is, could you provide the latest on mpox vaccination for children in the DRC? Over to you, DG.
Thank you. Dr. Yap, Dr. Mercy, they will respond to the second question. As an African leader, let me first remind you, in 2024, the African Union Assembly gave the mandate to Africa CDC to support member states for this negotiation. I have to be clear and loud. the way Africa was treated was unfair. Europe, we had European Union sitting, we have countries sitting. In Africa, they didn't consider African Union. That one, just in case there will be another negotiation in the future, this is why Africa CDC is changing the global health architecture. We are part of that. There is no CDC in the world that is strong like Africa CDC, representing 55 countries, 1.4 billion people. Then we got this mandate in 2024. As you know, in May, we didn't manage to have an agreement. We went back to our head of state in February 2025. The Assembly again said, we want Africa to continue the effort to support member states to reach an agreement and to report back. We organized a number of meetings with our ministers. We recruited consultants based in Geneva to provide support to negotiators. We had some team members who went in Geneva. What we have today is the outcome of effort, but also flexibility from the African side. There is no ideal solution. We cannot say we got everything we wanted to get, but at least we have an agreement. Now, knowing that some part of the world are not part of this agreement, we need to think collectively how this one will be implemented. But that will be after May, when we'll approve that, we'll start to think about it. Dr. Yap and Mercy, can you please respond to the second question?
Yes, thank you, DJ. So to the question about the children, the first thing is to highlight that they represent an important number of the case, around 30%, but that will depend on the province and the countries. And in DRC is the only country where they have approved the vaccination for children 1 to 12 years. So it's important to commend that. So now, out of the 500 people that have been vaccinated, 40%, 39% exactly, are children. So it's important to also take that opportunity as an advocacy to the other countries are currently vaccinated, but who have not yet approved, to make it happen so that the children in those countries, Sierra Leone, Uganda, and others, also have the opportunity to be protected. Over.
Thank you, Prof. Let's check the next question. We have Agnes from New Vision. Agnes, if you can hear us, you have the floor. Agnes, can you hear us? All right, just take Agnes.
Do you hear me?
Yes, we can hear you. Go ahead.
Oh, okay, yes. Yeah, my question is, DG highlighted the need for vaccination to see that we are fighting mpox, we are eradicating it. But now the issue is, for instance, Uganda, yes, I see the data. Uganda is affected, severely affected, given the data that has been presented. But then we see we only received 10,000 doses of mpox vaccines. And these ones covered a few divisions in Kampala. Actually, there were 2 divisions in Kampala, leaving out some of the hotspots, districts where we are having also mpox. So my question to DG is, what's the rollout plan? Do we expect more vaccines for mpox as an intervention to fight or to prevent the disease? Thank you. Over to you, Edwin.
Thank you, Agnes. Let's take the next one before DG comes in. We have Makochi from BBC. You have the floor.
Hello.
Yes, we can hear you. Go ahead.
Okay, yeah. I wanted to be sure if I got correct the answer you gave to Emery's question. I know that the LC16 got approved for use in the DRC, but I'm not so sure about the deployment if it had started. I think the last time I did check, they were still yet to deploy. So I just need to be sure if it's been deployed. And I know the person who answered talked about 46% or 40 something percent, but I just need a little bit more clarity if it's been deployed and how that is going. Thank you.
DG?
Yeah, thank you. We have colleagues working on the supply chain in IMST. They will provide initial response, then I will provide some. Dr. Yap and colleagues, those who are working on the supply chain.
Yes, thank you, DG. So to the question by Agnes on New Vision, actually the 10,000 doses that the country has received was the first shipment. Since then, they have received 100,000 extra doses. And then we are really commending Uganda because in less than 2 weeks, they've managed to vaccinate 51,000 people, which make a total of 61,000. So currently, that's moving well. Now, considering the increased number of cases, they've requested a new allocation of 200,000 doses. So we have our TRC, which is advising us, will make the recommendation of whether those doses could be allocated to Uganda. And on the side of where the vaccination is happening, we actually have 10 divisions, including Barara, Masaka, and others, who are currently vaccinating. So it's not only Kampala, but it's actually all those different divisions. On the question on the LC16 in DRC, so the team for the Japanese cooperation and government is arriving in DRC on Sunday, actually, to follow up with the training. As we do speak right now, there are 50,000 doses of LC16 available, and the plan is to have 3 extra million in the next coming weeks or months. So this is the plan. The team will arrive, they will organize the training, and then they will agree on the rollout of the vaccination. Over.
Yes, thank you. I think it was more complete. Thank you, Dr. Yap. Back to you, Margaret.
Thank you, DG. We have Esther Nakazi, a science journalist from Uganda. Esther, you have the floor.
Thank you very much, Margaret, and thank you, DG. I just want an update about Sudan, because we know that there are different outbreaks that are happening in Sudan, and they are facing a humanitarian situation with the war going on. So I wonder what Africa CDC particularly, I know WHO is doing too much, but I want to know what Africa CDC is doing in Sudan. Thank you so much, and over to you.
Thank you, Esther. Let's get the next one before DG comes in. John Songo, if you can hear us, you have the floor.
Oui, merci, vous me suivez, je crois.
Oui.
Oui, vous me suivez. Allô?
Et nous
Yes,
vous
we can hear
suivons.
you.
D'accord. Merci beaucoup pour la parole. Merci aussi pour l'exposé du docteur et le travail de l'équipe de communication. J'ai 2 petites questions. La première question, en début de semaine, le gouvernement provincial du Nord Kivu a alerté sur l'apparition d'une maladie qu'on appelle anthrax, qui se transmettrait de l'animal à l'homme, notamment dans les zones périphériques du parc national de Virunga. Ça, c'était peu avant que comment dirais-je, l'Institut congolais pour la conservation de la nature, ICCN, ait aussi alerté sur l'apparition d'une épizootie qui proviendrait des hippopotames. Alors, je me dis, de plus en plus, aux côtés du fait que la province soit en crise sécuritaire, il y a aussi des crises sanitaires qui s'intensifient. est-ce que le CDC Afrique, en collaboration avec le ministère de la Santé du gouvernement congolais, peuvent nous rassurer qu'il y a des mécanismes qui ont été déployés pour suivre de près la question, pour empêcher que euh, cette crise humanitaire qui est à ses débuts ne vienne encore agrandir les souffrances d'une population qui est déjà, n'est-ce pas, victime de la guerre depuis plusieurs années. Ça, c'est la première question. La deuxième préoccupation, dans le briefing de la semaine passée, et aujourd'hui, le médecin, docteur, est revenu partiellement sur ça. C'est concernant le budget, les maigres moyens qui sont maintenant à la disposition du CDC et qui pourraient impacter sa façon de répondre aux urgences sanitaires qui, malheureusement, n'attendent pas que l'on s'excuse face à la présence des moyens. Mais je me rends de plus en plus compte que dans la planification du CDC, c'est comme si les médias partenaires, les journalistes, tous ceux qui contribuent à relayer ces voix ne sont pas pris en compte. Est-ce qu'il y a un plan d'accompagnement des journalistes qui se donnent bénévolement à les accompagner dans ce qu'ils font pour leur permettre, ne fût-ce qu'accéder même à la connexion, pour assister le CDC dans ce qu'il fait, dans ses tâches de servir les plus des milliards de la population africaine. Merci beaucoup.
Thank you, DG.
Okay. Sudan is a major concern. Sudan is an example where we see security affecting the way we can respond to outbreaks. Since April 2023, we have 13 million people, 13 million people displaced. And we have more than 15 million people facing some challenges in terms of nutrition. We have more than 70% of hospitals in Sudan destroyed. Is this partner? It's not Africa CDC that will build infrastructures. And today we have cholera in Uganda, in Sudan. Around 1,500 people already passed on since July 2024. We have malaria, dengue, measles, because people are not vaccinated. How can you reach out people if there is insecurity? Because people, they don't have access to basic services. And the government of Sudan is investing less than 5% of their national budget to health. You see, it's a combination of so many factors. It's not Africa CDC that can come to address all of these factors. We are talking with political authorities in Sudan to address what they can address. Security, we need security. We need access to people. Then we can continue to do our best. Nevertheless, it's our role to support. We have our team in Sudan doing what they can do. But we say, as for the eastern part of DRC, it's also responding to the question from John. We don't have access to people. And we believe that if Sudan and eastern part of DRC and some regions in the western part of the continent, if we have peace and security, it will end. I think, Margaret, we are the best person to respond how you are supporting journalists to better communicate about what Africa CDC is doing.
Yes, thank you, DG. We have a number of strategies in place. We have media roundtables that we involve and journalists participate in across the different quarters that we have. That is one strategy. And the other one is an upcoming public health fellowship, media fellowship that we're establishing and working with the Africa Union Media Fellowship that will involve 5 or up to 6 journalists across the continent that will be empowered and mentored in terms of public health reporting. So those are some of the strategies, and we'll be reaching out to the different journalists across our network. Thank you, DG. And with that, we have come to the end of the briefing this week. DG, I'll pass it over back to you for your closing remarks.
Thank you so much. As we saw, we need to be led by science. And on the 17th of May, we have the Emergency Consultative Group, ECG, that will meet to tell us if we need to maintain the status of public health emergency of national security, or we need to lift that. In any case, they will tell us how to continue to implement the response plan 2.0 that we have in place. We are not saying it will be the end of Mpox. We say we need to do things differently. We also know that the major agenda today is the health financing in Africa. We are continuing to do our best to provide support based on the 3-pillar strategy that we developed, and we'll put in place a high-level committee that will work with Africa CDC to roll out this strategy. And we also know that local manufacturing remains a major agenda, mostly in the context of so many outbreaks. For all of that, we are having an integrated approach, and we need to have medical countermeasures in Africa. The last point is to bring more innovation, as we saw in Abu Dhabi. We need to see also Africa implementing the AI. I think this is something we are working on that and will implement very soon. I think with that, Margaret, I thank you. I thank all colleagues, journalists, and we'll meet next week, and I will give some updates. I think next week I will be maybe in Washington. We'll give update from Washington.